Good morning and thank you for staying with us. And in case you're just joining us, we begin health and lifestyle right now being Wednesday. And today we want to talk about effective referral of patients, what this means, what it looks like in practical sense, what are some of the principles and the practical steps that usually happen before a patient is referred and transferred from one facility to the next. What are some of the challenges and proposed solutions on how best we can be able to ensure that each and every patient gets the right kind of care at the right place at the right time? And to help me talk about this, I'm hosting this morning Dr. John Simiu Tabu. Dr. John Simiu Tabu is the head of emergency services at the Moi Teaching and Referral Hospital in Eldoret, Uasin Gishu County. Asante sana for creating time.
Yeah, thanks, Safin, and thanks, viewers, for tuning in.
Yeah, we are excited to have you, Dr. Ari, all the way from Eldoret. And of course, we are happy that you've also been able to hold, this particular position in various hospitals. So we will be borrowing from your wealth of knowledge and experience from the different facilities just to understand what usually happens before a patient is taken from one medical facility to another and what informs that decision. Having worked for the Nairobi Hospital, the Department of Emergency, also before you became the head of emergency at Moi Teaching and Referral as the assistant clinical, director of clinical services, you were at the Kenyatta National Hospital heading the casualty department. I'm very impressed by, just how much you've been able to do in the medical field. But once again, karibu.
Asante.
Let's begin from the very basics. We usually don't want to assume that people know, like today we're talking about a referral system. If you were to describe an effective referral system in the simplest term, what does it look like?
Now, thank you, Safin. I hope I'll not be able to say too many medical terms.
That's why I use the word simplest.
Now, an effective referral system. So you can see we are talking about a system. Mm-hmm. So we're not talking about an event. We're talking about a system which then involves this person here that we are calling a patient. Mm-hmm. And it involves some transport. Mm-hmm. And it involves facilities. Okay? So we're talking about this patient being at a lower level facility. And there's a mechanism now of identifying this patient who requires to be moved by whichever form of transport to now seek services at a higher facility or where the specialized service is available. And Safin, again, when you talk about patients, sometimes we assume that referrals are only for patients. We may refer a patient physical, mm-hmm. But we could also say, no, we are not moving the patient. Why don't we take a specimen from this patient and move the specimen instead of the patient?
Okay. So that's still falling under referral?
It's still falling under referral.
Okay.
We may also say, look here, now why don't we just investigate and move what you call the client parameters? You move the parameters, you move the X-ray, you move the CT scan, mm-hmm. for now a consultant to have a look at it from the other side. It's a form of referral. Mm-hmm. But we may also say, no, look here, don't move the patient. Why don't you move the expert from where they are mm-hmm. to where the patient is?
So what informs the choice of what you've run us through, the physical referral, referring maybe the specimen? Mm-hmm. What as medics, what helps you make that decision? What circumstances are you looking at?
Now, many circumstances, and again, when we talk about patients, we may then need to look at it like the emergency patient. Mm-hmm. You may want to move an emergency patient, and that means you literally move the physical patient. A patient who has been involved in an accident, a patient who has a heart attack, if I may use that kind of term, you will then physically move the patient. So again, it depends on the diagnosis. Mm. It depends on the reason for moving the patient. But there may be a patient who just needs to come for some specialized service. For example, kidney, for example, oncology, for example, diabetes, the so-called non-communicables. You may want to move that patient, but not that fast. Okay? And you may decide and say, okay, look here, why don't we just move the parameters? Why don't we move the labs only? So again, it depends on the kind of patient we are talking about. Is it an emergency patient? Is it a non-emergency patient? Number one. Number two, where are you moving the patient to? Now, that is a bit interesting because then you may then need to look at it and say, how far this referring facility and the receiving facility, how far apart? Now, which mechanism is going to be used to move this patient from the referring facility to the receiving facility? So there are quite a number of variables, if I may use that term, that would determine a patient referral or a specimen referral or an expert movement, yes, or a parameter movement.
All right.
Yeah.
In Kenya, I know we have 6 levels of care. Maybe you can run us through those levels of care. You know, many Kenyans, you talk to them, they just know hospital. They don't know levels, they don't know what. Whenever they don't feel well, they just know, I'll go to the hospital. But when you're talking about an effective referral system, we need to even understand the levels of care that we have and what usually informs where somebody should go first before they go to the next level. So maybe debunk that for us and the variance that are there between, you know, the 6 levels of care that we have currently in our system.
Okay. Now, we begin with the community. So the lowest level will what we call the community structures. And let me just name them, then I'll say something around them. So from the community, you then you go to the clinics. You then go to the dispensaries. You have the health center. You have the sub-county hospital. You have what we now call the level 5 hospital, which are teaching referral. And then we have now the level 6. So all the way from the community, which is the lowest, up to the highest, which is level 6. Out of this, you may then realize that anything from the community up to level 5 would actually fall within or under the county. Level 6 would now be the national referral facilities, which we may be able to say they're tertiary. Okay? And so when now we come to the organization of these levels, we have now what we call the community health promoters at the community level. Now I'm talking about the community.
The CHPs.
The CHPs. And the CHPs are now a group, a number of, they take care of the community. They are a responsibility of both the national government and county government in terms of diagnosing. They're involved in some form of diagnosis. They're involved in some form of minor treatments, but they're actually a linkage from the community now to the next level. And they're organized part by the national and also by the county governments. Now, from there, we go to what would appear like the clinic. So you can actually see the community health promoters are in the community. Now, we get
and I like the fact that you've started with them, because many people don't consider them, like, if they are sick, these people, like, it's the way you'd say, I'm not feeling well, I go to a hospital. So I don't think we've gotten to a space where we are recognizing. I think now we are, since the UHC journey really gained momentum and the launch of the Social Health Authority, we are beginning to find significance in the community health promoters. But for a very long time, they were not considered as a very crucial step in the 6 levels of care that we are talking about.
Yes, they are a very important element because, again, we have empowered them to do particular things. Okay, mainly preventive, promotive. Okay, but we then have them now involved in minor treatments. A patient who has fever, they actually are allowed to give the medication for fever at that particular level. So they are empowered to some level. They can be able to give some particular drugs in terms of dispensing, and that's what we then have at that community level. They're a very important link. And they're also the ones now who pick data, data where it comes to, let's say, registration of patients into, let's say, the SHA system. That are a very important component in terms of picking up that particular documentation. But more importantly, that are linkage, okay? That are linkage to the next level. Now, once we now get to the next level, then the next level is the clinics, which then the person whom we see there, the human resource, we see there is the nurse. Okay? And then we have, so 1, 2 nurses are actually in charge of that level 2, what we'll be able to call now level 2 facility. Okay? And they are allowed to diagnose, again, heavily preventive, promotive. Okay? But the nurses are trained now to assess patients, diagnose, and actually be able to give some medication to a particular level.
So the minor treatments.
The minor treatments, if you like. But some of them could be life-saving treatments.
Yeah.
Because you see, you may have, let's say, pain in the chest. That nurse should be taught or is taught how to recognize that chest pain and what to do at that particular level.
Okay.
And the closest to the community, right away from now the community into now the first health facility. Okay? Now, once we are done with the clinics, then we go to the dispensaries, yes, and then from there now we go to the health centers. The only difference here is that at the health center level now, we now are introducing the diagnostic services. Mm-hmm. Yes, level 3 health center, we now introduce the diagnostic services. Now we bring in the other staff, including the laboratory staff, where now the lab technicians are able now to take, blood or whichever other specimens like urine, and do some form of lab work. So you can see now we have now moved from the nurse being the team leader at a lower level to a health center where the clinical officer now is the team leader.
So that's why sometimes you'll be told, go to this specific facility to get these tests done.
Yes.
Okay.
And yet, again, Safin, let me confirm that there are some facilities that have actually brought down the lab services now to level 2. And the health center, and then in the health center, you have the clinical officer, you then have some minor surgeries, you then have some laboratory tests to a limited extent. You also now have introduced in records, you have also introduced in other personnel. So that's the health center level, okay? And actually health center level, we actually have deliveries.
Yeah, yeah.
Okay, we have delivery. So you can see now the progression.
So you don't need to go to a level 6 to have your baby.
No, that's a bit interesting. And that's why the talk today is more about referrals.
Yeah, that's why I wanted you to run us through the 6 levels. Because the ordinary Kenyan will wake up today, aseme, hii hospitali kubwa, that's where I'm going to get everything I need.
Yeah.
So they wake up and that's where they go.
Yes.
But then we forget that we have 5 other levels.
Yes.
That could have provided that very same service.
And we like that. Quite a number of clients like coming to higher levels. But Safin, imagine that what we are then saying here is that a delivery, if it's not a high risk, a mother who has delivered before without complications, okay? Without complications, not a cesarean section, maybe this is a second delivery or third delivery, can comfortably deliver at a lower level, okay? And the workforce, the clinical officers, the nurses, the midwives, are trained to recognize any dangers at that particular level, okay? And when there are any dangers, like, for example, a mother bleeding, maybe a delayed delivery, maybe the baby getting tired, then this is now when they now initiate a referral, okay? They initiate a referral to now a higher level, which can then be able now to say, okay, this mother may not deliver in the usual way. Maybe they may require a cesarean section, for example, or they may require some procedure, for example, blood transfusion, okay? So you can then see that by the time now we are reaching level 4, we are now introducing in the specialists. We are introducing in the medical officer, but we also are introducing in the specialists, including the obstetrician and gynecologist. So you move this patient here now who was in the process of delivering, but there's a complication that occurs along the way. So we now move this patient from level 3 to level 4. So we are encouraged to, if we are not high risk as such, you should be able to deliver from the health center.
No, but I want you to convince a Kenyan who feels, we've had people say, oh, that hospital doesn't have doctors, it doesn't have the equipment, your hospital in Indogo, that's why many people maybe don't go there. But then I want you to convince Kenyans, what do we do to these lower level facilities? How do we, inspire confidence in Kenyans that they can actually get the service that they seek in this?
Now, and they're right, Safin. They are right Because then maybe the times they have visited the level 3 facility, you may find that the human resource is not adequate. Okay? Maybe they only have 1 or 2 clinical officers. They go in and the clinical officer is tired. They may not have enough nurses, midwives, if you like. Okay? So maybe the time now they went into labor, unfortunately this nurse may not have been there, gone for training. So it comes back now to just enhancing our HR to make sure that this level 3 facility is covered throughout. Because labor can come in any time. So it just then tells you that this nurse, the county system, the national system, must ensure that there is adequate human resource coverage. And human resource which is trained to, let's say, carry on a delivery. Human resource which is trained to recognize an emergency and intervene. But even as you do that, and we remember the building blocks called the WHO building blocks, you also then need the medicines and products. Okay, so you deliver and you begin having a complication. You must then be able to have the drugs that you can be able to give this client in order for her to stop bleeding. I'm just giving that as an example. Yeah. Okay, so it then means that even now when this building is there as a health center, and this is again where now the complaint comes in. Yeah. What does it have in terms of human resource and coverage? What does it have in terms of the real infrastructure? Because once you deliver, you require some particular infrastructure around there. This baby may require oxygen. So the health centers that we have, do they have oxygen? Yes, either in the cylinders, do they have oxygen in that infrastructure in order to support the baby? Yeah. Okay, can they be able to keep the baby warm? Can they pick up complications after delivery and then say, okay, looks like we cannot manage this complication at this health center. Can we be able to move? So a health center is not just there for the building. In fact, that's now where I come in and say, maybe it's the highest time the government and the Kenya Medical Professionals and Dentists Council and other systems, they should be able now to revisit the designation of these facilities because we know what's supposed to be in a health center. We know what's supposed to be in a sub-county hospital. So it should not just be there by name. We should...
Do we have what should be there?
Yes, so that can be confirmed then by the systems, Kenya Medical Professionals and Dentists Council, including now even the financing system that we have.
I want us to understand what, because you've taken us to the level 4, let's talk about level 5 and 6.
Good.
There's been complaints about some of these facilities. In fact, most of these facilities are overwhelmed by the traffic of patients. I know that there's a lot that's being done to ensure that we address that problem. But for a very long time, we've been having the influx of patients at these facilities. What were they meant to address initially? And then where did we probably miss the point? Now that we're having so many patients who could be treated at the lower levels but are going to the level 5s and the level 6 probably. Why is this still a problem?
You see, Safid, now, and maybe that's, thank you for inviting us. That's why we're here. So what we are then saying here is that according to the current classification, a sub-county hospital has the medical officers, it has the clinical officers, it has the nurses. In fact, it now has the specialists, okay? The basic specialists. Is it the gynecologist, the pediatrician, the surgeon, yes, the physician? So if we then had this system where the sub-county hospital then had that kind of structure in terms of human resource and the infrastructure, then this Kenyan is then going to be very proud to say, look here, I will actually go to sub-county hospital such and such because I will get everything I want. And if there's an emergency, then they have capacity to manage, okay? Why we get overwhelmed at level 5 and level 6 is exactly that. That, you see, there are these clients who should be going to the level 3. But maybe because they missed a service, and maybe they went there and the personnel are not there. And then the habit then is bypass. Oh, okay, when you get over there, or the clinical officer is not there, or the medicines are actually not there, and they now bypass even the sub-county hospital, which is level 4, and they come to level 5. And sometimes they actually come to level 6. Now, this is a problem. And the problem here is that, look at it this way, Kenyans have spent a lot of money saying this level 5 and level 6 are getting into some sub-specializations, okay? By the time you are arriving at level 5, you already are getting into some specializations, okay? Now, you find a client who ideally has a fever, has a minor ailment and should have gone to level 3. But this client now has come on a queue at level 5 and has come on a queue at level 6.
Level 6, yeah. This should not be the case.
It should never be the case.
This should not be the case.
And that is why we now need to get back into the system and say, where is the rain beating us here? Because then you find that these level 5s and level 6s have actually now are handling what I would call the ambulatory patients, who ideally should not be at, the level 5s are what in the past we call them provincial hospitals. PGH Kakamega, PGH Garissa, PGH Coast General, PGH Embu. These institutions have now some form of specialization. Not just a gynecologist, but a gynecologist who is now doing some specialized procedure. By the time you are arriving at now the level 6 facilities, including Moi Teaching and Referral, including KNH, including the spinal injury unit, including Maternity, for example. Now, these are now super specialized services. So you actually then can imagine, Safin, that you then now begin attending to quite a bit of the crowd. And the lower you are at that level, we have crowds. Okay? The community is a crowd by itself. By the time you are at the health center dispensaries, a crowd. The health centers are crowds. So you can actually imagine now this crowd, which has come over to us unannounced.
Does this affect the outcomes?
It does affect outcomes. Because then, Dr. Smith, who is a specialist, this other doctor who is an oncology specialist, this other one who is, a kidney specialist, is now forced now to handle what I would call minor. Sorry to say, maybe to a person it's not minor.
Yeah, that's to the patient it's life-threatening. That fever, that whatever they are going through, to them is life-threatening.
To them it's life-threatening.
Yeah.
But now when it comes to, are we utilizing resources well? The answer is no. Yeah. Because then, what then will be happening with this clinician who is at the health center? If all of us have moved from the health center to a level 5 to a level 6 facility, okay? So that is why I think we just need to go back. We need to refocus and say, look here, can we make sure that we actually have enough human resource infrastructure, we have enough medicines and products at these lower levels, and maybe through a system like SHA. In fact, through a system like SHA should be able to, and it has said it, that we're going to cover you, right away from the community level up to all the levels. So I think SHA should assist us in implementing the referral system. First of all, Safin, we have said there's documentation, correct? The community health promoters have already picked documentation. When they go to the health center, there is a communication system whereby the clients are seen, because SHA knows, yes, Dr. Smith has presented to the health center. Actually, there's some payment related in the system. So I think the same SHA then should also encourage, so first of all, I think it should be involved in the HR, it should be involved in infrastructure, it should be involved in reclassification of these facilities, and if possible, supporting these facilities. Once that happens, SHA then should also now be able to move together with Kenyans so that they encourage Kenyans to seek services at those particular levels. Okay? Interesting, I was hoping today to be with Brian. Somehow he's not here, Shenga. But unfortunately, look at it this way. In fact, for me, the story is then about, so what happens to private facilities? Because it's very easy then for us to talk about public facilities, okay? Yeah. Public facilities, because somehow they have some command structure, okay? But what of private facilities? What of mission hospitals?
How does that network work?
How does the
is it coordinated? How is the referral system working? Yeah,
exactly. That's a good, for me, that's where I come in, Safin, and I say, now, I think now we need order. We can, okay, again, unfortunate that you then have a referring facility. We literally have been guided by counties. So you find a county like Uasin-Gishu, a county like Kakamega, but there are some parts of Kakamega which are closer to Uasin-Gishu than to Kakamega on the other side. Yeah. So we may then look at it more in terms of the distance of referral. So if Turbo is closer to Uasin-Gishu, maybe these clients around Turbo can still come to Uasin-Gishu. So we should not have boundaries, number one. But number two, then these private facilities, why do they just decide that they are not under command of the county? Because they are not really under command of the county. No, private facilities are running ambulances. They are running their own human resource. And they will decide, okay, I'm coming all the way from a nursing home in Kitale, for example. I'm not going to Kijana Wamalwa county referral. You know, there's a Kijana Wamalwa as a level 5 in Kitale. But the clients are not going to Kijana Wamalwa. Somebody in a private facility, and even a government facility decides, okay, Kijana Wamalwa is 100 kilometers away. Why don't we just go directly to Moi Teaching and Referral Hospital? So we have a problem. So it then means that we then need to have somebody command all the facilities, private, public.
I get what you're saying. So there's need for a well-coordinated network between the counties, first of all, one county and another. And there's also need for the coordination between the private and the public facilities as well, so that at least the network is clearer and the patient gets the right service at the right time at the nearest, facility if possible. Right? I get what you're saying. Let's talk about how then this system should work. Before a patient probably gets from one facility to the next, who should make this decision, and how does it work?
That's where the difficult comes in.
Yeah.
Human resource. That it means we then need to have somebody on the ground at the health center level, at the nursing home, at the private facility, who then can be able to say, yes, we have assessed you, but from our assessment, we think that this illness cannot be managed here. Okay? Now, once that happens, there has to be a coordinating center within the county. And by the way, if I talk about within the county, I would actually be wrong, because we cannot have 47 coordinating centers. No, those are too many. Okay? If you are in Vihiga, which is a tiny small place on the other side, and is next to Kakamega, and the next two counties around the lake, there could just be a central coordinating center.
For that region.
For that region, for referrals. And that's why then I miss the provincial kind of focus, because then the province was bringing together all those counties. Okay? But what am I saying? I'm saying that we then need a central place for coordinating referrals. Now, that central place should involve both the private and the public. But you did ask about then on the ground. So on the ground, we must have a human resource that says, yes, we cannot manage this patient here because of our limited resources or because of want for specialized care, number one. But number two, that coordinating office then must know, okay, but this kind of client, is it an emergency client? Obviously, if you have a heart attack, acute coronary syndrome, that we call it in medicine, then you cannot wait. It then means, even within that system, there has then to be this patient who can be rushed quickly. But as you're talking about rushing the patient quickly, Safin, then how are you going to rush this patient?
The transportation.
The transportation and the standards of transportation. Where I sit as head of emergency, you may find, unfortunately, Safin, less than 15% patients are being brought by ambulance. Less than 15, maybe even less than 10.
But how many of those ambulances do we have? And then the other question then would be, whose responsibility in terms of the cost is it? Because sometimes it's left upon the family to pay the ambulance to move their patient from one facility to the next. And probably they don't have that money. So,
But now, Safin, this is now where the tricky thing comes in. Safety during transport. Okay? You have a heart attack, or you actually have had an injury, after an accident. You actually have a fracture of the long bone. Okay? Can you imagine you being pushed in some taxi, small taxi, or usually, a pro box, and you see, so the bones which are supposed to be like this, with a bit of some traction on or some splint on. So you can imagine now being forced into this small vehicle. You actually create more harm by moving this patient into this taxi, injuring more muscles and more vessels. Yes, and ultimately now when you receive these clients here, somebody they have come 6 hours away. Somebody has come. Our referral, MTRH receives, our referrals is half of this country. We actually get referrals from 24 counties. Okay, so you actually imagine Turkana, where it is, 700 kilometers away. Now, this patient has to be moved by road an accident victim.
And it's an emergency.
Has an injury in the head, the injury is getting worse, the clotting is getting worse. By the time the patient arrives, you certify the patient dead.
Yeah.
Okay?
But then what do? You cannot, as a family, you cannot afford to airlift your patient to Eldoret, plus the caregiver, because they cannot come alone. Sometimes it can become a bit overwhelming.
Wonderful.
For some of these families.
Lodwar, sorry to mention names here. Lodwar is a level 5, and that's where we come back again to. Lodwar is level 5. Since Lodwar is level 5, we're expecting Lodwar to have now the specialists. And you should then be able to look at Lodwar and say, look here, what are the common conditions around Lodwar? Correct? So if you know that conflicts, including arrows into the chest and accidents in the head are common, it then means that as part of the national government and as part of the county government, we then need to encourage Lodwar to have a neurosurgeon, for example. We then need to have Lodwar have an orthopedic surgeon, because then we cannot afford. Can you imagine putting, patients on the road every day? How many ambulances? Are you talking about? Yeah. And so you bypass Kitale and come to Eldoret. And
sometimes they advise that in the ambulance there should be a doctor or to accompany
in the ambulance,
because anything can happen.
Interesting.
Standard practice.
And this is not time to talk about again even our state of ambulances. But this kind of patient, you're not going to move this patient in a taxi, for example. Yeah. Okay, human resource, the basic ambulances would actually have an EMT, an emergency medical technician. But by the time now you're moving to the next level, then you need paramedics. You may need nurses, you may need intensivists to actually move. Yeah. First of all, how many of them are there? So the solution is stay back and say, look here, can we make sure that Lodwar has adequate infrastructure, has adequate human resource, so that we can be able to sort out as many patients in Lodwar as possible. So my position is then only move these patients to MTRH, patients who now need super specialized care. Even kidney patients, now there's dialysis happening, Safin, everywhere. Yes? So Lodwar should be able to do dialysis. Nakuru, PGH should be able to do dialysis. Narok, which still refers to us, should be able to do that. Yeah. And then, when now you are dialyzing and there's a complication that arises, or you need a cardiovascular, you need a cardiothoracic surgeon, that is now how that patient should now be referred. Because there's need now for a super specialist. Narok does not have cardiothoracic surgeons. Kenyatta has, but then they can decide, okay, which is closer? Is it Kenyatta or is it MTRH? Yeah. You can imagine, obviously, Narok, Kenyatta is closer. And we really don't mind when clients say, oh, we are still going to MTRH. But you can see the kind of client now we are referring. We are referring because then we are offering basic services at the initiating facility. We are referring then because now we need a specialized service which is available at MTRH, which is available at KNH. The same thing about Mathari. There are special mental health clients whom Mathari cannot have everybody. It then can only have those that then qualify to be there. But remember, we are now talking about moving. So
if these lower level facilities are equipped with the right equipment and the
human resource,
then it eases the burden for the higher level facilities.
100%, and even the utilization of resources we would save as a country. Yeah. We cannot have ambulances on the road. Where I practice, on a Friday, you have 20, 30 ambulances arriving at the same time. They have not called.
Also, that's another challenge. I wanted to understand the communication and the linkage between these facilities, because as I was prepping for this show, one of the biggest challenges was the fact that there are so many patients who arrive at a particular facility that they've been referred, but this referring facility did not communicate to the receiving facility. So how ideally, how should it happen? And currently, what are some of the key challenges that we are facing in terms of the communication and the linkage between the referring facility and the receiving facility?
Interesting.
Yeah.
We have talked about coordination, and now we are talking about communication. Okay? Now, the best examples elsewhere is the same way you have a police line. Let me now give the example of the police line. Yeah. Or the Safaricom line. So the best would really be that if you are in a particular county and you make an emergency call, the must should be such that it's that service that's available within that radius. Okay? So you already see, Safina, I'm saying, do we have a toll-free line as a country? Because again, you are calling, you have an emergency, but you only have some 2 shillings, you know, the phone goes off. You can no longer continue having that kind of conversation. So 2 issues about communication. Number one, that coordinating center should then be the one in charge of communication. So not everybody can actually wake up and say, I'm going to MTRH. This coordinating center, and at some stage, we actually were there, and maybe this is again where SHA can be able to assist us, that for you to move a patient, let us have a coordinating center. They don't need 47. They could actually be 8 in this country. Okay? So everybody around the lake, why don't we have this coordinating center, coordinate all referrals?
We have a Lake Region Economic Block, Coastal Region Economic Block. So you're saying we can borrow that idea to this other side?
Exactly, so that we have coordinating centers.
Yeah, okay.
Okay, and by the way, the Coast General has actually a cath lab. So you may find that Nakuru, instead of them then getting a patient from Nakuru to KNH, a patient can as well be flown to Coast General because they have a free cath lab at that time. Our cath lab maybe at MTRH may not be working. MTRH should be able to fly that patient to Coast General or to Aga Khan, for example. Again, private facilities have their own issues. But so we should be seeing referrals coordinated at a regional level, but even at a national level. Coast General is free. Coast General has a cath lab that's available. The consultants are available, because it's a race against time. Okay? So you can see some coordination running regionally and coordination actually running in the course of in the country. So toll-free line, okay? Number one. Number two, coordinating centers. Number three, obviously now, which platform? So we are saying, as a recommendation, maybe we should not be on telephones. We should be able to use the relevant platforms, either Safaricom or SHA, to then, remember when we began this show, we said you actually can move a parameter, a client parameter. You can move a client's X-ray. You can move a client's CT scan. So why don't we then have a platform, the way now we have ICT hubs, the way now we have bandwidth which is high. Why don't we then have a platform where you sit, and again, the person who moves the patient, and I think trying to answer you, should be the senior-most doctor. You do not want a doctor in a level 5 facility to leave the referral to the lowest person, talking to a higher facility and taking too much time. You really want this doctor at level 5, the doctor at level 4 to say, cardiothoracic surgeon, I'm a consultant such and such, I have had this surgery here, but I think in the course of surgery I came across the difficulty. This is the difficulty I have, and I'm therefore moving this patient either by flight or I'm moving this patient by an advanced life support ambulance. So you already can see I'm introducing terms like an ambulance, which is basic, and an ambulance which is advanced life support. But you can see the person communicating is the senior most clinician at that level. Okay? Yeah. So it should not really be that colleagues are scribbling something. Actually, they're not even the ones scribbling, they're leaving it to, you know, somebody else lower.
Do it.
And now when you read the referral, you just wonder what exactly happened.
What do they mean even?
Exactly.
Is there an attachment of proper documentation that shows even the lab tests?
And by the time they have come, the patients forgot the lab tests, or they forgot the scans behind and they're carrying CDs. The systems we have cannot read the CD. You can imagine, Safin. Yeah. So a patient comes in and now you say, oh my.
It could happen. Before a patient and their caregiver or the family leaves one facility to the next, what should happen at the referring facility, on the road, and at the receiving facility? Good.
That's standards. In fact, this is why I actually carry this document. The actual guidelines, the guidelines which some of us were part of, in 2014, I did assist in authoring the referral guidelines of 2014. Okay. I don't know whether that has been reviewed. But we have guidelines as a country. It's called the Kenya Health Sector Referral Implementation Guidelines.
Okay.
We actually have guidelines. Yeah. So what we are saying is, can we then have colleagues, can we have this country adhere to the referral what?
Guidelines that we have already.
We do. Yeah. So what we are then saying is, at the initiating level, you have seen the client, so there must be a determination of this client is for referral. Number one. Number two, which documents, what have I done to this client so here? Far, yeah. I have done labs, I have done CT scans, I even have done surgery. Correct? And we then expect now you to make an envelope to say, okay, this ambulance is going to move in the next 15 minutes. Please, nurse, confirm, checklist. Do we have everything that we have done around this client? But even as you do that, you then make a telephone call. And quite a number of the institutions, MTRH, have a referral form. And MTRH have a referral number. Kenyatta the same. So we are then expecting the senior doctor, the senior clinical officer, and then to say, Dr. Simiyu, we had this kind of challenge, and this is where now even...
So you call before the patient arrives?
You call before.
Okay.
And you can even send the parameter, send the scan, and say, Dr. Simiyu, what's the interpretation of this? Because these days, again, with ICT, you literally can send the scan. These days, they just scan. And they send on what's up on the other side. Yes. Oh, you thought that the patient has a bleed in the head. I don't think that patient has a bleed in the head. You don't even need to move the patient. That patient needs ICU care at your facility.
Okay.
You see what we are saying? Now, so you can see the standards at the initiating facility. But once now you say, MTRH says, please move, then there has to be some bit of communication. Likely, we like people moving during the day. Because at night, there are complications along the way. At night, when it comes to the number of staffs we have also is at a minimum. You don't want doctors who have been here throughout the day, 8 to 5, they're tired, and being called at midnight. So we really like clients being brought in during the day because then you are a team of specialists. You actually can be able to receive these clients. But it may also be that this client does not necessarily need to come to the emergency. It may be that this client needed to come to the renal clinic. This client needed to come to the hypertension clinic. This client has a stroke, and because it has already happened, we already have advised what kind of medication you should be able to provide the client. So these receiving facilities have consultant clinics, okay? So don't crowd the emergency. You already have a copy of the consultant clinics. Bring these patients to the relevant clinics, and you are going to be received by the consultants on real time.
But that can only happen if there is proper communication.
Exactly.
And the family is well guided on where exactly to go. Yeah?
And how.
And how to go there, yeah.
Okay? So you can then see you are done there. You begin moving, and obviously when you begin moving, because this patient here is very sick, for a very sick patient, and you remember I said the emergency one and the non-emergency one. Okay? Delivery is an emergency. Heart attack is an emergency. A stroke is an emergency because you see you are in trouble there. You may want to reach this facility at the earliest time so that we see whether we can actually go and remove the clot. You know, a stroke is an emergency.
Yeah, yeah.
Blood is blocked somewhere, and you may need to take this patient, let's say, to a lab where you can put in a small catheter to open the blood vessel that's supposed to supply that part of it.
As soon as possible.
As soon as possible. Yeah. Within 4 hours. 4.5 hours.
So distance also is of essence. Which facility are you going? Which is the nearest where this...
And that's why, Safin, you cannot run away from evacuating patients by ambulance, by helicopter. And I was very happy at some stage, northern Kenya, we actually had quite a number of philanthropists running services, helicopter services, to go and pick clients, emergency patients, delivery or otherwise, to bring them to Lodwar. But when they bring them to that Lodwar place, then there must be something happening. Okay, this ambulance, a patient who is literally going to be moved by taxi is a patient who should not be on that road, is a patient who ideally should come to the clinic. A patient whom we expect is going to move on that road is a patient then who must have a paramedic, but mainly an ICU nurse, maybe a doctor, to move this patient safely. Because, Safin, we have actually had patients being put in an ambulance, and somewhere along the way, the patient vomits, and the patient vomits into the chest, and by the time you are receiving the patient has pneumonia, aspiration pneumonia. So even just...
Some don't even make it to the next facility.
They don't.
Yeah, some don't make it.
You will be surprised, Safin, that what we call brought in dead, where I'm working at Moi Teaching and Referral Hospital, is 1 to 2 patients per day, and it's very sad.
1 to 2, yeah. 60. They left the other facility alive, something happened along.
Something happened. 60 patients we receive, 40 to 60. It cannot continue. And yet, the issue was handling. But again, let me now say this, unfortunately, Safin, that it's also possible that you may have done your best, but the choice of moving this patient you should not have moved the patient. And now that comes to what kind of services can we be able to offer, even at the initiating facility? Okay, unfortunate to say this, but if you are having a relative who needs end-of-life care, sorry to say, this person has cancer, the doctors have told you the cancer is advanced, and you have been cancelled around the same. I'm aware that we are in denial at that stage, and sometimes we still want to move the patient. But and a significant number of our clients who come in really are for palliation.
But the family still insists. And that's where the problem is. I want us, because I have very few minutes left, let's talk about that. Dealing with the family and their requests and sometimes demands. That's why I asked you, who should greenlight a referral? Because in some cases you find the family complaining that the hospital took too long. And probably that's why we lost our loved one. Or they knew they couldn't handle this matter, but they kept our person there for long enough. So how do you deal with these complexities? And also talk to us about the challenge of self-referrals, because there is that a lot.
Tricky. We are sorry to lose clients. As doctors, we really want our clients to live. There's no doctor who would want the client to die. And yet, nature is such that we'll still lose them, even if we have done the best that we could do. But just now to come to these issues of then referral, remember what I've said is a coordinating desk could have a senior person in charge of the referrals. That's my message. That coordinating desk in the various regions could have then somebody to say, you benefit. But for us, what we have allowed the community to do, not the community, the referring facilities to do, we have given them our telephone number as MTRH. So they call. And what now happens with the referring nurse, so we have a 24-hour, not one line. In fact, there are about 3. Pediatrics, obstetrics, gynecology, the adult emergency. So we actually have lines. Now, and these lines have been circulated to the 24 counties that refer to us. We even get referrals from across. In South Sudan, we get referrals from Rwanda, across. So what then happens is that they call. Now, when they call, there are issues that the referral desk can handle. So we have a whole coordinating room like this called a referral desk. Now, if this referral nurse cannot handle, then the referral nurse will be able to forward the phone to me. Dr. Simiyu, I am unable to handle this. Could you kindly advise? Or we actually forward that to the specialist. A neurosurgeon, could you quickly look at this and advise? Pediatric surgeon. We have a patient who, a neonate born with abnormalities. And this is one of the areas, again, that we have done very well in terms of training, capacity building, Safin. In our catchment area, we actually have trained counties on moving babies, moving newborns who have complications. Yes, how to move them, how to call. So there is actually a line just to the pediatrics. Yes, and there's already an advice on how do you safely move. This child should be warm. This child should not feed. 1, 2, 3, 1, 2, 3. Correct? Now, self-referrals looks like, again, this is where now the rubber meets the road. It's a very difficult thing to say. If the service is not available at the facility you thought, if the service is not available at level 4, if it's not available at level 5, it's not available at the nursing home that you are in, or somewhere along the way, Safin, you reach somewhere and, the costs, the cost. We have been here, and on a day we are actually paying 50,000 shillings per... Yes? So the relatives decide, we are moving.
And it's their right?
And so do you want me to say, no, don't move? So you see...
it's their right.
It's a right. A right to health, a right to a choice of, a right to emergency.
Right to second opinion and a third.
Right to second and third. But the problem here is that as you do that, now that blocks care at now the receiving facility. And the complaints come because then this person did not, again, you don't expect them to write a letter. But you then imagine that things are happening on a Friday and everybody has decided to come on Friday. You have trained the ambulance on Friday. How do these people... And they have been with the patient for the last 4 or 5 days. Okay, so the issue of can I move is right for Kenyans. But maybe this is now where the issue of family physicians, this is where the issue of the kind of service provided at the lower level comes in. But I think for colleagues, let me say this, is availability. If we had the senior most of the doctors, the senior most of the clinical officers, the senior most of the specialists available to give opinion, Kenyans would not move. Kenyans are moving because we are not, either we are not enough in terms of numbers, or we actually are not there.
Or nobody is giving them the right information.
Or nobody is
the assurance, what they need to know.
Exactly.
Yeah.
So I agree that people will decide to move. I agree, but let them know that even as they do that, that then means when they come to us, they also now have to be patient, because you can see you actually have received 15 patients, 15 ambulances at the same time.
See, kusema ati we went, they left us, we were on the queue for hours, and unfortunately, you know,
we lost the patient.
Yeah, but sometimes it's really unfortunate. But it's good that you were here, because you really helped us understand what usually happens behind the curtain. It's as patients are really pressed by their current issue.
Interesting, Safin. Yeah. So if you, now again, we have something called categorization. We have something called triage, Safin. If you have 20 patients out here, you then sometimes are even forced to go out there and look at each one of them quickly. We call that triage. And then look at it and say, out of these 20 patients, whom should I begin with? Because we have 6 emergency rooms operating at the same time. We cannot push in these 20 patients at the same time. Okay? So now that's where now the issue comes in, because you as a relative, you want your patient to be attended first. Yeah. Naturally. Yeah. You want your child to be seen first. Yeah. But then the doctor says, okay, thank you very much, but I want to begin with this number 20, because if I do nothing in the next 3-4 minutes, I'm going to lose the patient. Yeah. So the doctors have been taught to triage. The doctors have been taught to prioritize. A patient who comes in and is convulsing, for us, is emergency number 1. A patient who comes in and this patient here has a stroke, that patient is important to us. A patient who comes in and has heart attack, we know that we'll lose that patient. So even amongst the 20 patients, I think what I'm saying here is that allow the doctors to make that decision, because they have been trained to make that decision at the best time.
Thank you so much, Dr. We've learned so much, but what quick things I'm getting from you, you know, just the conversation we've had. We need to strengthen the primary care and ensure that they have the right people, the right equipment, and what is needed to be able to help the public get that assurance that they can get the services they want at the lower level, so that the higher level facilities don't have to be overwhelmed. We also need to really formalize the pre-referral communication, so that that coordination is well clear and guided. By the time the patient is leaving one facility to the next, both you know, facilities are in line, are inclined in what they need to do. There's also need for us to really look at the human resource, train and retrain if possible, because you could, that clinical officer, that nurse could actually be the game changer, the lifesaver at that level before we reach to the senior doctor. Thank you so much, Dr. Your parting shot as we close.
Just to thank Kenyans for allowing us to have them. Safin, I've been a doctor for the last 36 years.
You were joking about how long you've been around this street.
And out of that 6 years...
Do I tell them?
Yeah, why not? Why not?
No.
Out of that 6 years, 25 have been in the emergency, so that is home.
Yeah, yeah.
That's home.
36.
And for me, glad that I'm serving Kenyans. I didn't indicate that I'm actually a lecturer. I'm a faculty at Moi University. Yeah. Where I teach surgery.
We can down the information to us.
Yes.
It was like a very good class. We've learned a lot about the referral.
Yes, so let's digitalize the service. Let us adhere to protocol. Let us enhance infrastructure, human resource at the low level. And let us get the working systems like SHA to step in and create order. Let us re-categorize these facilities. I think it's not just a name, Safin. If it's not a health center, it's not a health center. Putting a name there will not change. If this is not a sub-county hospital, call it a health center. So that then the Mwananchi will then go to the health center than now going to another facility. But I think for me, that's a message. Thank you, Kenyans, for listening.
Thank you so much
to us.
Thank you so much, John Simeo, for creating time for us today, coming all the way from Eldoret. He is the head of the Emergency Services Department at the Moi Teaching and Referral Hospital in Eldoret. And today we were talking about effective referral of patients and what this looks like in practical sense. And we thank you so much. Asante sana for watching. We do this again next week, Health and Lifestyle every Wednesday. We want to welcome you to suggest what you want us to talk about. Is it a condition? Is it an issue in the medical field? We'd like to do that with our experts. Asante sana for now. It's a wrap. Have a lovely day ahead.